I'm non-operative sports medicine, so my background is actually in the emergency room. It's where I did my primary training and did a fellowship in primary care sports medicine. So I spend all week in the clinic seeing people for a variety of things, including probably like 25% of my patients with like vague shoulder pain that ends up probably being degenerative rotator cuff. So we'll talk about some of the cuff pathology, and then some of the things that I'm doing from the non-operative standpoint to help get these people better, and then some of the strategies that you guys use, I'm happy to hear about, and this can be like very interactive. A lot of these are just like kind of pictures, and then we can talk a little bit more about ways to collaborate to give people the best outcomes moving forward. So everybody can hear me in the back, Kyle?
Oh yeah.
All right, sweet. All right, so here are some of the objectives, figuring out what the cause of these tendinopathic etiologies are from, what medical procedures we're doing in the clinic, and then strategies to appropriately load these healing tendons after we do these procedures. So kind of what are the differences, right, between these different things? Because tendinopathy is really a spectrum of disease, right? It starts with an initial insult that disrupts the collagen fibers with inflammation and edema in those tendon fibers, and then people say, oh, hey, I'll work through this, and they end up getting a little better, getting a little worse, and then 6 months has gone by and you look at their MRI and it looks like somebody took a lawnmower and just ran it over their shoulder a bunch of times on the inside. So when that shift from the acute inflammation to the chronic problem comes on, that's where we struggle to kind of get those people into a place where we can get good tendon healing and allow the tendon fibers to come back together in a meaningful way. So a couple pictures here. This is not in the shoulder. Trying to remember if this was an ankle or maybe a biceps, but tendon sheath here in the middle, and then there's some swelling around that as it runs over the bone. This is maybe a post-tib is what it looks like in long axis. So I do a lot of ultrasound-based procedures and a lot of diagnostic ultrasound to assess cuff tendons in the clinic. But there are a few strategies that we use to do that, including just a normal B or an M mode ultrasound, and then something called power Doppler, which is what this is. So this is actually an Achilles. I'm using these different tendons to show the diagnostic capabilities of our ultrasounds now in the clinic. We can oftentimes tell small partial thickness tears all the way to full thickness in the clinic with an ultrasound the same day that we see patients without an MRI. So this is neovascularity in a thickened Achilles tendon, and you'll see these people for their ankles that have obviously very thick Achilles that you can almost palpate. But this is something, if we see extra blood flow in a rotator cuff tendon, even if we don't see big tears, it's a sign that there is tendon disease there as the neovascular structure changes to try and give more blood flow to this tendon. And then obviously, one component of degenerative tendon disease, especially in the shoulder, and this is a supraspinatus, is these calcific densities. And that's something that we see pretty frequently and that there are strategies to address as well. So tendons adapt slowly because they don't have good blood flow. They're watershed areas, and it's difficult to get them the nutrients that they need. On top of that, the cells that make up tendons, the tenocytes and the chondrocytes that live next to the tendons and the cartilage, again, are very slow. They don't really do a whole lot after you turn 18, 19, or 20, right? They stop doing what they did for your growth period, and they start to shut down and stop producing collagen fibers. So when you have these overloaded states, the tendons don't do a great job repairing themselves, right? Just a couple pictures of those tendon structures, and then some pathophys, which I haven't looked at in a long time, but down in the bottom right-hand corner about what happens in a tendinopathic rotator cuff. And then obviously this is kind of where you guys see more when you're working with people with shoulder pain. Oh, hey, in sports, rest is a little bit of a dirty word. Hey, we got to hold you out, and hey, I got to throw, I got to play, I got to do my sport, and it's hard to give the tendon the rest and then load it appropriately to give them the time frame that they need to fix things with the tendon structure. So, and then especially in the shoulder, the scapular kinematics that come into play with rotator cuff pathology. I see almost everybody has poor scapular protraction and inability to elevate the scapula and assist their shoulder and overhead movement, which leads to more compression of that supraspinatus and the tendon structures there. And we see inflammation of the bursa, and overhead activity becomes more and more difficult. So these are some of the intrinsic factors, just age, metabolic disease. There are a variety of factors that can contribute to development of these tendon problems. And the degenerative tendon breakdown that we see so frequently here. Questions so far? Everybody rolling? Awesome. So again, differences in our history can make a big difference in how we evaluate and treat things. So just good history is really what this slide is about, and important in figuring out what the root cause of the problem is so that we can treat it appropriately. And then these are kind of, again, the 4 ultrasound findings. So increased density or decreased density, neovessels, thickening of the tendon, or disorganized fibrillar patterns are the mainstays of ultrasonographic diagnosis of tendinopathy in really any tendon. So, and then kind of what I'd like to just update you all on is really the most up-to-date procedural things that we're doing in the sports world to reset chronic inflammation, give people a good shot at getting in with you all, and then having a good chance to get back to doing what they love doing with appropriate load and a good therapy program that transitions to a maintenance program at home that they can keep doing. So if I see this or something like this, this is acute tear of the supraspinatus, then I call that guy. So this is a little different than obviously the degen tears that we see, and the procedures that I do don't generally fix this, although sometimes people do have this large tear and can do pretty well as long as they're if they're not a candidate for a cuff repair with Trevor. Therapy can often strengthen those cuff muscles around the cuff, and scapular kinematics can improve their function even if we don't go in and fix something like this. So there's 3 kind of big things that we do. So PRP is the first. A lot of people are doing PRP now. The data on PRP for tendinopathic areas, especially in the cuff, is pretty mixed. So there's not a ton of great studies with big data that show really great outcomes in the long term. So when we do tendon PRP, it's a specific formulation called leukocyte-rich PRP, which is a pro-inflammatory kind of protocol that the machine keeps some of the leukocytes in the formulation, keeps a little bit of the red blood cells in the formulation. And the goal is to stimulate all of these growth factors, cytokines, and interleukins to really put a stop to chronic inflammation and turn it into an acute inflammatory process. When you've got a degenerative cuff tendinopathy, whether or not there's tears, starting from square one, giving it a couple week break, 5 to 7 days if it's small, up to 2 weeks if it's large, and then starting a therapy protocol with isometrics, and then progressing to eccentric loading, resistance band work, and then eventually like plyometrics and concentrics can actually give the tendon the tools that it needs to heal itself. So the big reason it does this is it gives the tenocytes kind of an on signal to create new collagen fibers and start collagen synthesis again. That can be real helpful if you have small tears or really disorganized tendon tissue.
And just a note about PRP in general, like I'm sure you have your patients asking about it. Like if they have been in the wrong clinic, like cash, like multiple $1,000s, it's not really a control, product or service. Dignity in general will do it at cost, kind of just for the equipment. It's pretty standard, like $600, $650. I'm not really upcharged from there as a service. So if people that have kind of failed everything are really looking for that, I think it's a good option. kind of want to protect people from the like $10,000, whatever it is.
Yeah.
Because people could really charge what they want if you end up in the wrong clinic.
Yeah, as another aside just to that, you'll hear people talk about fat aspirate or bone marrow aspirate injections. Respectively, the data on all of those is about the same. The difference is, again, PRP for general big centers are somewhere between $600 and $1,000. The private practice regenerative places will charge $2,500 for it, and they'll have you back for 3 sessions. So you're in the hole and it's cash only. BMAC or bone marrow aspirate's over $10,000. So if people are asking about those things in general, the data suggests that they're not that much more beneficial at a significantly increased cost for the patient, which ends up being, unfortunate for them if they take $10,000 and the bone marrow aspirate doesn't work. We do PRP at Mercy and then downtown at Joe's. It's a pretty simple procedure. I draw the blood, or one of our nurses draws the blood. We use the ultrasound to place the PRP, and I actually also do a microfenestration of the tendon as I go through. That's kind of what we colloquially refer to as poor man's PRP, which is just a 22 gauge needle and about 20 to 30 passes through the tendon that's diseased. It stimulates blood flow to the area and mechanically breaks down diseased tissue. So it's kind of a minor tenotomy, essentially. Questions about PRP?
Yeah, actually,
yeah.
I know it's individualized to the patient, but they're going to ask us, they'll probably ask you, what's the likelihood of success with this? So what do you tell them?
Yeah, good question. So based on the data, it depends on the tendon that you're targeting. So PRP in the lateral epicondyle, the plantar fascia, patellar tendon origin, probably somewhere in the low 80% range. For the rotator cuff, the medial epicondyle, the Achilles, it's variable based on the study, somewhere between 40 to 75%. So I tell people in general, if we're going to do PRP, I almost always start with a small needle fenestration and try it. And if it's successful and we don't have good outcome after therapy, then PRP is more likely to be successful because they had a good response. And that variability comes from a variety of factors. Probably the biggest is what's your baseline platelet concentration. At the University of Colorado, where I trained, we would analyze everybody's PRP. And the variability in samples from people who are the same age, playing the same sport, could be 500,000 platelets per cubic centimeter times 10 to the fourth, so what, 5 billion versus 12 billion, so double the platelet concentration. Some people would have 20 billion. So it can be very different in terms of the sample, their hydration status, what does their hemodynamic status look like. So all of those can play a role in kind of this success rate. People taking anti-inflammatories up to a week before you draw a blood sample for PRP can affect the outcome of the PRP. So we don't understand enough about PRP to say that it's a great tool, but it is certainly a tool in the tool belt, and people like it because it's low risk, it's their own blood product, and it's easy to do in the clinic setting.
Why is it not covered by insurance yet? Why is it not covered?
It's a good question. FDA deems it an experimental therapy still. So TRICARE covers it. I would expect in the next 5 to 10 years that leukocyte-poor PRP for joints, especially like knee and hip, should be approved. I don't know what the process will look like for leukocyte-rich tendon-based PRP. So this is the procedure. This is a little bit of PRP, just in a tendon sheath there. Obviously not a cuff, but this is something with a small split tear in the Achilles, and that would be done in the office same day. PNT, or peritoneal tenotomy, this is something that I tend to push people towards because it is covered by insurance and the outcomes are generally pretty similar. So for cuff, elbow, Achilles, the variability and success rate is somewhere between 60 and 80% with this. I find that probably the better factor of this procedure is not the bleeding, but actually the mechanical disruption of diseased tendon and a pro-inflammatory response that can then stop chronic degenerative pathology and kind of turn it back to an acute tendinitis that can then be loaded appropriately with you all.
Is there a similar protective phase after this or not?
Depends, yes, it's a good question. Depends on the location. In the cuff, absolutely. So generally 5 to 7 days. There are a variety of different cutting devices, like the 10X, the Tendinova, the 10Jet, which I'm sure you've all heard of. In those situations where it's a much larger needle, it ends up being usually a sling for about 5 to 7 days, and then a week off of any like overhead lifting activity. So. Generally, if you're using a bigger needle, anything above an 18 gauge, it's going to be about 2 weeks for the cuff. This is not a cuff picture. Sorry, I don't have great cuff pictures, but this is a lateral epicondyle percutaneous needle fenestration. So just in plane with the ultrasound probe here on that ski slope sign, and as the common extensor bundle comes in, they're drawing the arrow around that common extensor bundle, which is thickened and not real fibrillar. So, and then shockwave. So, shockwave is kind of gaining traction. Really, really good for lateral epicondyle, medial epicondyle, plantar fascia. Radial shockwave is probably not as good for the rotator cuff, just because it's the way the beams travel is more of a fan. So focused shockwave can change the focal depth of the sound waves to target deeper structures, but really nobody in town does great focused shockwave because the machines are very expensive. So a lot of the people in town are doing shockwave therapy with a radial shockwave machine, and if you're doing it on the shoulder, the success is going to be somewhere in the 30 to 40% range, so not great. The theory behind shockwave is the same thing as similar to PRP and percutaneous needle fenestration. It's disruption of tendinopathic tissue. And the big mediator in shockwave is actually nitric oxide, which increases collagen synthesis. So it recruits all these other things, tumor growth factor, VEGF, PDGF1, probably some macroglobulin 2A, which all, again, help with cell proliferation and collagen synthesis. There aren't good studies on radial focused shockwave in the cuff yet. So I expect as the machines get better and become cheaper over time that it may be a better option for degenerative cuff tendinopathy. But right now it really is not super helpful. But it's non-invasive, it's well tolerated. If people have $75 to $125 per session for shockwave, it's a reasonable thing to try if they've had recalcitrance to other measures.
You do it?
It's a good question. So yes, I know I've trained to do shockwave, and then I asked Dignity for a machine, and they have not approved anything over the capital cost requirement for shockwave at this time, which is something that we often run into. So there are a couple of places around town. Most of them end up actually being chiropractors who charge like $300 or $400 a session. So again, just like Trevor was alluding to earlier, trying to stay away from kind of the predatory business practice of shockwave is something that'll be important for people in general. So at a large academic center, shockwave costs $75 to $100. And that's what it should cost. And the data on shockwave for tendon purposes is 3 sessions spaced a week apart. So shouldn't be any more than $200 or $300 for a full series. So kind of other things, I don't do a ton of these, but topical nitroglycerin can be useful if it's like at the footprint. If you've got a supraspinatus or a subscap that's really, really distal at the attachment site where there's less skin to get through. The reason that works is it stimulates nitric oxide production, vasodilates, and brings new blood flow to the area to allow the tendon to heal. And then there's some people that are doing this ultrasound guided scraping and neovessel ablation, which is kind of where you take the needle, You go in, and then it's a kind of a blunt needle tip. You flip it 180 degrees and then run it up against the tendon and the peritoneum interface. And that's pretty hard to do unless you've got really high quality ultrasound and the right needles. But like early studies looking at like 12 to 15 patients look like it's pretty beneficial for just stimulating some new vessels, and it's a little different than just stabbing it like with the percutaneous needle tenotomy. So yeah, Tori.
Is there a certain size of tear that this is more or less successful with as well?
In terms of like full thickness,
yeah,
full thickness
at a
or
certain
full
point,
width.
you're like,
Yeah.
You're referring over.
Yeah, I think it's a good question. I find that a lot of the times, like our older patients who have got these degenerative, like rotator cuff tendons, I almost always try and give this a shot because, and correct me if I'm wrong, I'm sure it's very difficult to stitch back that tissue if you were even considering doing something like a repair because of how thin the tendon tissue is and what it turns into after years and years of degeneration.
Yeah, you're getting into the meat of my talk here. But
Oh, sorry, all right, yeah. Meat and potatoes.
I am not needed for this problem.
Yeah.
I think you and you guys are what solves this problem. My last ditch resort.
Yeah. So I'll try things most of the time, but I've sent Trevor a bunch of people just to have the talk, and I think having them chat with them and kind of using that whole approach as the non-op and the operative side is very beneficial for people to hear. And then comes to you guys. So generally, I think like for me, kind of a less than 3 out of 10 pain approach is beneficial, but very specifically for the shoulder, I prefer pain-free rehab. So pushing people over pain limits in shoulder rehab is something that I would try to avoid. And then progression framework, which is stuff that you guys always do. HSR is not for this talk. I adapted this from a different chat. All right. Other questions? This is not relevant for this stuff. I think that's it. Questions about non-op management of degenerative cuff?
What are the waves of shockwave? Is it just sound waves?
Mm-hmm. Yeah, so it's an ultrasound-based technology. You've heard of lithotripsy for kidney stones, like where they blast stones with sound from the outside. It's actually that same technology that's repurposed into like a little small handheld device. It looks like a little Nerf gun looking thing. And it's like a 10-minute session. We just put a bunch of ultrasound jelly on and then ramp up frequency, pulse number, so you can go anywhere between like 2,000 to 4,000 pulses, and then you deliver that at a set frequency and a bar pressure. And then if you have a focus shockwave machine, you can adjust the depth that those sound waves meet at. So radial shockwave is just a fan out. Focus shockwave is a cone in, and you can adjust the focal length where those sound waves meet. So.
Is there any like heat or like any other like side effects with it?
Good question. Super low side effect profile. No, it does not generate heat signals. I mean, maybe a 1/4 of a degree at the very most, but it shouldn't do anything to burn patients. So. Cool.
We'll have time for questions and continued chats after this. For those that don't know, I'm Trevor Staub. I am a orthopedic sports medicine surgeon. I grew up in Pennsylvania, went to med school in Geisinger, and then did my residency in Buffalo, New York, and then fellowship in Minnesota. So I think I went from the snowiest place in the country to the coldest place to the hottest place. So I only do extremes. It's funny, like a talk about degenerative rotator cuff tears with a non-op and operative, portion of it. For me, like the operative portion is still non-operative. I basically built the talk to hype you guys up because I think you play the biggest role in this problem for people. And we'll get into the depths of why that is. So talk a little bit about the biomechanics of degenerative cuff tears, who are the patients that will get better without surgery? You know, I think that's what, you know, Tyler and I spend a lot of time trying to suss out when we see patients in the office, you know, reading research on who those people are. And then timeline too, like when will they get better? You get all kind of people coming in with, you know, I've had pain for 10 days, I've had pain for 10 years. So that means, you know, very different things as far as the timeline for them to improve. And then, you know, ultimately, which degenerative cuffs should we operate on? So, you know, as most of you know, the biomechanics of the shoulder, like the goal of the rotator cuff is to put the ball on the socket and allow the deltoid and the big muscles to work around it. And problems arise when that disruption is created, either, you know, subscap or supraspinatus. When that coupling is lost, the shoulder function, you know, goes to crap. In degenerative tears, you know, we as humans, we do so much with our arms overhead all day, every day. So when you drive your car 200,000 miles, the tread wears out. The rotator cuff's exactly the same. This is a normal aging process. When you look at patients over 70 who say, I don't have a shoulder problem, over, you know, nearly 70% of them have rotator cuff tears that are full thickness. So this is something that is normal, and because it's this slow burn over time, it allows that neuromuscular adaptation that allows them to say, hey, I don't have a shoulder problem despite having pathology on MRI. And that's the real, you know, crux of rotator cuffs. So the guy that's putting up his Christmas lights and falls off his ladder, dislocates his shoulder and has a full thickness supraspinatus tear, that one doesn't belong in your guy's clinics or in his office. Like, they need surgery. That, you know, disruption's gonna lead to very acute, you know, problems for them, and much higher risk of them getting atrophy earlier, so these degenerative cuff tears, the success is wildly more successful than the acute full thickness traumatic tears. So, you know, when we look at the, you know, outcomes of traumatic full thickness rotator cuff tears, so this is just one study in the journal Shoulder Elbow Surgery of 40 patients. Basically, of the 40, 50% failed PT and underwent surgery. But when you look at the people that kind of stuck it out and said, hey, screw you, doc, I don't want surgery, it doesn't really matter, ultimately the satisfaction was significantly different. So those with the traumatic cuff tear that was torn, you know, it was about 50% satisfaction rate compared to almost 85% for the people that got acutely fixed. So the take home is, you know, the patient that has an acute full thickness, you know, retracted tear, that patient generally is going to do better with surgery. Now, part of our job too is it's not just about the, you know, pathology, it's about the patient. So sometimes people are too sick for surgery, and that's when you can still offer them a lot of benefit even with an acute full thickness tear. But for an otherwise healthy patient that's active, in general, get them to my office. They're going to do better with surgery. So when we look at the folks, you know, ultimately who is going to get better in this degenerative rotator cuff group. So this study always blows my mind. It comes up often in residency group chats. A 10-year outcome study where they'd followed patients for 10 years, 450 patients, atraumatic, and this is so full thickness tears. This isn't just degenerative, you know, partial thickness tears. So the mean age is around 60. PT was successful in almost 3/4 of the patients. And this improvement they made with physical therapy was maintained over the entire decade. So they did their physical therapy session. It's not like they're doing PT the whole time. They followed up like 10 years later and they were still doing well. And this is one of my favorite ones. The strongest predictor ultimately for their success was the patient's expectation and belief in PT. That's something I'm sure you guys have heard all the time, but it's crazy the people that come into my office are like, oh, like, PT, I don't want to do that. It's like, that patient's just going to do bad, like they're not going to do great. And sometimes you force them, right? It's like, hey, no, like you kind of have to do this, let's see if you're going to get better. But they come and you see them and they're moping in the corner and they don't want to do anything, and they're just waiting to come back and see me to get surgery, when ultimately they could have avoided the whole thing.
You can send all those mopey ones to Tori.
Yeah.
It's really good with that.
Whip them into shape. But this is a great counseling take home for me. So even with full thickness degenerative tears, 3/4 of people improved with PT for 10 years. Now, we'll talk about this a little bit, like ultimately when the rotator cuff is has a full thickness tear, it has a timeline and an end date on it. So at some point it'll become unrepairable. Now, they may never have a problem, they may never have a function issue, but it's a discussion to have, especially for the person that's still having some type of symptoms. But either way, this speaks to the great success that physical therapy offers for these degenerative slow burn rotator cuff tears. And this is just another randomized control trial in the New England Journal of Medicine. 80% of patients with degenerative, so we're talking about partial rotator cuff tears, who received supervised PT reported reduced pain and improved function at 6 months and a year. This number kind of keeps coming up, this like 80%, 75%, and I think it kind of comes across that degenerative rotator cuff spectrum where you have a good chance of making most of these people better. So when we look at all these studies, the factors in favor of PT success, so we talked about the high expectations in PT. Other important factors are lower fatty infiltration of the muscle belly. So when muscles and tendons tear and they're off the bone, they like to work. They want to be attached. They want to fire. When they don't, they kind of shrivel up. Fat kind of overtakes the muscle. And when that is higher, I think it kind of speaks to how long it's been going on and maybe how over the hill maybe it is a little bit. And I think that decreases some of that chance of PT success. And kind of same line of thought, the shorter duration of symptoms, so same kind of thought process there. And then in general, when you look at the outcomes, kind of the partial thickness tears are going to do better. But as we just talked about, full thickness tears still have a chance to improve with PT. So I know you guys don't spend a lot of time looking at MRIs, but this is kind of what we talk about when we're looking at a partial thickness tear. I don't have a mouse here. So on the left side, these are coronal images. So humeral head and the arrows are kind of pointing. So on the left side, that is an articular-sided partial thickness tear. So we're looking at all these fibers that are coming down here. So this is the muscle belly of the supraspinatus. Neurocromian arrow over top, glenoid here, humeral head here, cartilage here. This is the tendon that kind of follows along. And so what we want to see is all the fibers making it. So bursal fiber and then empty. So that's a partial thickness articular-sided tear. Whereas this is a partial bursal sided, so we can see the articular fibers making it, but on the bursal side we have disruption. In general, patients tolerate articular sided a little better, so you can have kind of a bigger partial thickness tear versus some of the acute bursal sided ones will kind of push people to surgery a little quicker. And this is kind of a progression of rotator cuff disease. So on the left side, a full thickness tear, and then subtle retraction as kind of time goes by. So in the middle picture, we see the tendon kind of overlying the top part of the humeral head. And on the right picture, it's finally all the way to the glenoid. And so timeline, I think in all this is kind of important too. So like I said, at some point, these are gonna become unrepairable. And that time is certainly longer for the degenerative tear. So the person that is acute, that timeline is going to be a little different. But part of the problem is too is, it's pretty common in our field. It's like, all right, you showed up. All right, we got to go through the steps. Let's send you to PT. 6 weeks and we'll see you back. And that's like, if you're not better in 6 weeks, we're doing surgery, which seems ridiculous for a lot of these things that are a multi-year problem, a multi-year development. You're dealing with multiple years of disruption of mechanics and range of motion that doesn't get solved overnight. So when they look at the timeline of when people improved, it's progressive too. So this was a randomized control trial, the one we saw earlier in the New England Journal of Medicine. So this was partial cuff tears. They basically didn't see a ton of difference in pain and function with the PT at about 3 months. But when they looked at the people kind of double the time, around 22 weeks, they saw significant improvement, and that continued to build and improve as time went on to 6 months and a year. So it's not only those early 6 weeks effort, and some people do get better in that time, but I do worry about the patients that show up, and they're like, yeah, I did PT, didn't make me any better, let's do surgery. I'm like, well, wait a second, like, how long did you do PT for? How many sessions did you do? What did you work on? And these are the answers I get all the time, like, oh yeah, I did it for 6 weeks. Well, how many sessions did you do? Well, I went to 3, I had a vacation, I didn't do the other ones. I didn't do any of the home PT exercises I was supposed to do. what kind of stuff do you do? I did pendulums, I did this one, and I did the kind of this one. And I'm like,
These weren't spoon patients.
no. Well, they might be, but they don't listen. So it speaks to the person that doesn't want to get better with PT, and they're not going to get better because they don't put the work in. But so this patient I'll see that failed conservative treatment, even for longer, 3 months, they'll show up to my door, like, come on, let's do surgery. And I'm like, all right, well, did you give it an honest try? And sometimes when you like really push them in a corner, they're like, no, I don't like really think so. And so some people are going to pick surgery no matter what. But I think it's important to really educate them that, listen, you're controlling your scapula. You're improving range of motion in the shoulder that hasn't been there for who knows how many years. You're creating endurance to maybe a partial thickness tear or the remaining rotator cuff. So all that just takes a lot of time. And I think telling patients that, kind of builds their confidence in what PT can do for them. So how much time do we have to fix these full thickness tears? And this talks about acute traumatic tears versus the degenerative tears. So the acute person, the person that fell off their ladder, critical changes can kind of happen within like 3 months' time. And in general, the surgery just gets harder for me when, not for everyone, but most people should be there and are probably going to end up there. So those are the patients that I don't think going through the steps of you need to fail conservative treatment, those are the patients you kind of want to get in a little quicker. Now for the degenerative tears, when they look at the study, it's years. So 3+ years for moderate atrophy, sometimes 5+ for the more severe atrophy, and that's getting to the point where we can no longer probably repair it, and we're getting into a whole other talk of tuberoplasties where we're SCRs and that kind of stuff, balloonplasties. So this is kind of how the Goudier classification, a lot of French words in the shoulder world, and when you look at these stages, 0 is kind of normal muscle belly. So obviously in the top part of the little wishbone there is your supraspinatus. And if you look at that specifically as we go down the line, so we start seeing some streaking in stage 1, and then there's more muscle but more fat, and then it's to the point where fat is overtaking muscle, and there's basically nothing left. That's the patient that, even if it has some mobility, I'm not sure how functional that muscle is going to be for them when I repair it. So that's when we start getting into the conversation of these full thickness tears, and it's a conversation too. Like, I think there's a good chance you could do well with PT and maybe never need me, but there's a point where I can no longer help you, at least with arthroscopic surgery. Now, reverses and all that stuff can potentially help down the line. And for the patient that is active and not really having any problems, I have a hard time pressing them to surgery. So I think truly failing physical therapy is an important thing for me to jump and do surgery for these degenerative tears. So this is kind of an easy take-home point, but when you guys cannot make them better, I'll fix them. Like, my job's easy. You go in and we put the cuff back down. We do things to try and initiate the healing, but ultimately when they fail all these other things, that's when I come into the picture. And it's as simple as that really when we talk about the indications. For degenerative rotator cuff tears, they should fail conservative treatment. Nobody should be taking these people to the OR right away. I think that's kind of a disservice to the patient. I think they have a good chance, especially for the partial tears. I think they have a good chance of getting better. So this is looking another randomized controlled trial of non-surgical and surgical treatment for rotator cuffs, 400 patients. Everyone was initially given kind of 3 months of PT, so that was kind of going in, and then they underwent a MR arthrogram if they were still symptomatic. And basically 200 got randomized to additional PT or surgery. So equivalent results were found for pain and function in patients without full thickness tears. Now, we've looked at other data that talks about people can do better with full thickness, but I do think that's a caveat. The person that is maybe, I'm better, I'm 50% better, but they have a full thickness tear, I think that's a patient I'm quicker to jump to kind of help with surgery or offer surgery. But true degenerative partial thickness rotator cuff tear, they should exhaust months of physical therapy in my eyes before they have surgery, because I do think they have a good chance of getting better. And then the statistically significant improvements were found in the pain and function results for the surgery group with full thickness tears. So I do think that is a caveat, especially when you look at the outcomes. A lot of the times you'll see better results. So just a summary, atraumatic degenerative cuff tears, they happen slowly over time, and that's what allows people to adapt. both full thickness and partial thickness degenerative tears show improvement with PT, and we'll see the 75%, 80% number a lot. So I think that's a number you can quote to your patients. They show up with partial thickness or degenerative tears. A lot of them are going to get better. Many will improve in the early weeks, but reminding people that this can take more time. You've been, have altered mechanics for a long time. It's not going to happen overnight. So just quitting after 6 weeks, I don't think is always the move. Excellent outcomes have been shown for operative treatment of full thickness tears. So full thickness rotator cuff tears that fail to get better with you guys, we'll fix. Although, as we've shown for the patient that's not as healthy or just doesn't want surgery, PT is still a really good option even for full thickness tears. And this obviously goes for Tyler too. This is my cell. Please put it in your guys' phones.
Text Trevor with questions to me.
Yeah. And then Tyler, I know this goes for you too. Any patient you'd want a second opinion on, we'll get them in pretty much same day if we have office. And obviously this depends on, people in Phoenix are very territorial. So if they live on the east side, they don't want to go to the west side. And so depending where I'm at and he's at, same day, next day, we'll get patients in. Don't stress about like imaging. Like people are like, oh, they have to have their MRI. Like we'll take care of that. That's not a problem. We'll get their x-rays at the office. We'll get the advanced imaging if they need it. I, in general, keep space in my surgical schedule and office schedule for urgent cases, or I'll double, triple book. Like, we'll get people in that need to be seen. That's never a problem. Open up to the floor for general questions on the surgical side, non-surgical end of things. I got another rug rat on the way, so I'll be a little sleepier here next time we do one of these.
Oh man, you're gonna have your hands full 2 years apart like that.
Something like that.
It'll be fun though.
Little feeder.
Question, just the variability sometimes that seems to happen, or I guess with reading MRIs and what constitutes the partial thickness tear, full thickness tear, and just the variability in that.
Yeah, so it's the nature of our world in medicine. It's the same thing with PTs and evals. Like you're going to get different answers whoever you talk to. I know most orthopedic surgeons, they look at their own imaging, so I think it's at least you get 2 eyes on it. So you're going to get the radiologist view, you're going to get the orthopedic surgeon's view. And honestly, with Tyler, with the advent of ultrasound, I think it adds a whole nother layer in of dynamic kind of evaluation of these rotator cuff problems. So if I'm unsure, and there's questions of MRI quality too. So like depending what center you go to, the magnet isn't as good. So sometimes people get a poor MRI. If you're really concerned and you're like, oh, I think they have an articular sided tear, you can get contrast involved. So I'm never too worried. If we're talking about somebody getting surgery, hey, get another study done. And obviously there's like costs involved with that, but I think it's worthwhile at times. But I think in most day and age, a 3 Tesla, a really good quality MRI, is pretty reliable for establishing those things. But I think a lot of it comes to that. Poor quality MRIs, they're moving, there's motion artifact, they're like, I don't want to go get another one, like I don't want to bother the patient, or sometimes it comes down to finances. But like I see some really bad MRIs, I'm like, I don't know what I'm looking at here, like this is hard to tell. But I think for a well-done study where a patient's able to stay still, they're pretty good these days.
Can you expand a little bit on the correlation, I guess, with articular changes or flattening of the humeral head and some of the rotator cuff changes?
With, you mean like more chronic tears or like arthropathy?
And then, when's the indication that you're going to still repair the rotator cuff versus now they're looking at the total shoulder? Oh,
yeah. So for me, the fatty infiltration is an important part of that. Okay. There's scoring out there. You have the ROHI, the Rohe score, is kind of a graded score that's out there where you essentially, it's their age, their activity level, the size of the tear, and they basically pop out a score for how repairable it is and kind of speaks to the, or using a patch and things like that. And part of it comes down to there are gray cases. So I'll have conversations all the time where you're really on the fence here. And there's good data too when talking about the patient that's unrepairable. Sometimes just addressing their bicep can give them significant pain relief. So there's nuanced kind of discussions with that, and that's almost a whole other talk when we're getting into tuberoplasties, SCRs, and that kind of thing. But sometimes it's a discussion with me and the patient, like, hey, we're gonna give it a shot. And there's good data showing even a partial repair sometimes will benefit patients. So it's medializing the footprint and creating their anatomy, basically a new environment where you can allow healing. So sometimes it is not repairable to their normal anatomy, but we'll adjust in surgery to kind of create for that. But I have those conversations all the time where I'm maybe not sure we can get this repaired, but they're not ready to consider a total and they're still super active, and I think it's worth a shot, especially when the biceps involved. We're pretty confident that's a factor. I think they're gonna get a benefit, almost no matter what.
Will you just send my phone number to?
Yeah.
I can type it up here too.
Yeah.
So a lot of times we'll get patients that are coming to us direct or from a primary care physician.
Sure.
And so they haven't seen an ortho yet, they haven't seen y'all. And we'll do the best we can, but sometimes we can assist. So for example, the patient I sent you over for the hydrodilation, it's like, okay, I need some help here.
Yeah.
Just a shout out to Tyler here. She did great, by the way. So if you have somebody that throws a shoulder, there's your man right there. But,
Blind squirrel nut thing.
when we look at an assist, sometimes there's a conversation not only about your controlled inflammatory processes that you mentioned, those interventions, but a cortisone injection.
Yeah.
So what makes you decide to go with or without that strategy, without or with physical therapy?
Yeah, it's a great question, Tori. So I think what you'll find kind of with my generation, all the newer trained sports docs, is that we're getting further and further away from just putting Kenalog or dexamethasone or Depomedrol everywhere. And what we find is that, they have a great pain response. Hey, my shoulder feels great, right? So feels great for 6 weeks or 8 weeks. But what is putting steroid, especially with a non-ultrasound guided injection into the cuff or the subacromial bursa, end up doing for them? Well, it'll drop the inflammation, and then that's kind of the antithesis of what we want, right? So I find that it is useful in kind of one scenario, and it's that they cannot do meaningful therapy because they have too much pain. And if that becomes the problem, then a steroid can give them the ability to do the right exercises with good technique with y'all's guidance. But in general, putting steroid around a tendon, and if you're doing a blind subacromial injection, could be in the muscle belly, could be in the tendon, might be on the articular surface of the humerus. You could go too far and be in the AC joint for all we know. You might be in the subacromial bursa. And it can be, relatively beneficial because it will disseminate through those tissues over time. But it will end up leading to decreased collagen synthesis, and then you'll just be back to square one after that 6 to 8 weeks is out. So unless they really do diligent therapy and get in and are doing the work after that, I find that I try to actually stay away from steroid for the most part in degenerative cuff tears.
Yeah, I don't really recommend it or use it. It's if somebody tells me, hey doc, it doesn't matter what you tell me, I'm not doing surgery, like, all right, this is something reasonable to try, do it along with your PT, I think it's gonna help you. But any patient that I'm worried may end up having surgery, I think it just makes everything more difficult. And I tell them this is not we're not making your cuff better, this is making your pain better, and it'll make you feel better, but it's likely not permanent. Now, if it allows you to do the therapy and you can kind of obviously do a good job with therapy, I think you can kind of overcome it.
Right.
But not really a part of my practice for patients with repairable cuff pathology. Now, the rotator cuff arthropathy, that kind of stuff, no question, I think it's a reasonable option for them.
Yeah. Yeah, so I do a lot of steroid injections into the shoulder, but it often is more for arthritis into the joint, or as an assist with frozen shoulder to give a little bit of pain control so they can break those motion planes that they're stuck in. So
When you're looking at the acute trauma, rotator cuff tear versus the degenerative, somebody asks me, what's my likelihood of a successful outcome if I go on and have a rotator cuff repair? Depending on those scenarios, what do you tell them?
You're asking the success with
surgery.
For both?
For both.
Very good, especially for full thickness tears. I mean, the patient I worry about is that they're forcing themselves into, or they were told by somebody, hey, you have to have surgery, and they don't have any other options. I think like that's kind of the negative, but for a degenerative cuff tear, full thickness that fails conservative treatment, the data is very good that they have and again, assuming reasonable activity level, the muscle atrophy is not significant, they have a very good chance of doing well.
What's very good?
Huh?
Like, what's very good? They're gonna ask me.
85%. Yeah. We looked at the one study, 85% versus so degenerative full thickness tears, or traumatic full thickness tears, 85% satisfaction versus 50 for PT.
Do you do toes?
Mm-hmm.
Where do you practice that?
East Side, Matthews, Weinstein.
Okay.
I think Jason spent some time with Brady doing them. One of our foot and ankle guys maybe is.
Probably traumatic reverse stuff, not really.
Right.
Yeah,
right.
little different thing.
Yeah.
It's like the patient that horrible 4-part proximal humerus fracture, doing reverse is different from the like nuanced anatomic, total shoulder stuff.
And don't get away from the shoulder. Tom John?
Oh, doing it? No. Yeah. Yeah, I mean, as far as, what I do surgery-wise, basically anything arthroscopic-wise in the shoulder, in the knee, and then the litany of kind of sports trauma, Achilles, patellar tendons, quad tendons, distal biceps, pecs, and then, some minor fracture work, which I guess you probably don't get a ton of fracture work that you're looking for a home for. I assume that kind of finds its way, but ankle fractures, clavicles, stuff like that I take care of. And then by all means, like there's stuff that me or Tyler maybe don't necessarily see, like we'll evaluate it and get it where it needs to go.
Right. Yeah, absolutely. I'm in clinic every day of the week, and I have a relatively large footprint. I spend half the week in Gilbert and then half the week in Phoenix, and then half day at Chandler. So I'm pretty much available all the time. So.
Dr. Staub, are you still splitting time between St. Joe's and Glendale, right?
Mm-hmm. And then I have
Where, Alicia?
St. Joe's and Glendale.
What?
Glenn?
Yeah.
What? Where?
Sometime in St. Joe's. And then
Westgate, it's called.
Westgate.
Yeah.
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 Is that freestanding or is that?
It's a hospital. Yeah. Smaller one.
It's west of the freeway, right?
Yeah.
On the rest of the freeway
Yeah,
there?
it's right. It's basically like 99th and Glendale. It's like right there.
I know where it's at.
I'm getting better. I'm not a native Arizona. I'm starting to get the little lay of the land.
It's in the west. It's in the west
Take a
valley.
referral to actually get an appointment with that interview?
You text me their number. The patient's going to get a call within probably hours or a day.
Yeah.
And then it's up to them as far as their schedule. So like if they're available and willing to drive where I'm at, like same day or the next day.
Yeah, and then Alicia can text us with any problems. Tori's texted me before, because what ends up happening is people will call a number a lot and it'll go to something called the PCC, which is just like a large phone system that the hospital utilizes to get people to the right area. The PCC's told people that I don't treat knee pain before, so it's not a very helpful service. But getting info to us, we can give it directly to our schedulers or one of our front office people to call the patient directly and get them put on the schedule. So I think most people have that experience with the PCC.
Yeah, I mean, it's the nature of a big organization. Like, they need big organization solutions, and it's just like what we need is a secretary with the phone, like mom and pop shop answering. That's like the best thing for patients and for business, but it's just not reality, unfortunately. I wish it was, but well, I'll bust my butt on my end to make it happen. I'm not worried about that, but I don't like when people kind of get lost in the shuffle.
Yeah.
So I'd rather work harder on my end to make it happen.
Yeah, agreed. Sweet. What else?
When it comes to your needle procedures, are you comboing that with shockwave, or are you doing them in isolation?
Good question. No, I don't do, the only two that I combine are the PRP and the needle fen, or the technically percutaneous needle tenotomy, but I find that one or the other generally creates enough of a pro-inflammatory process to get the tenocytes to turn on and start depositing new collagen fibers. So there's not any data that studies PNT plus shockwave or PNT even plus PRP. But if I'm going to do PRP and I'm already there, I'm going to put small aliquots of the solution throughout the pathology. I'm essentially already doing a fenestration of the tendon tissue. So,
I mean, probably the places that would do something like that are the private ones that are upcharging each thing and adding it in addition for all three, without definitive data that it's better than one alone or two alone.
Yep. And again, the shockwave for the cuff specifically is not very good. And then maybe the focused machines will get better with a true protocol that's developed by somebody. But if you have, again, tennis elbow, bad plantar fascia, I mean, the success rate for shockwave, radial shockwave in these superficial structures, it's like in the high 80s. It's like very, very good. It's tolerated well. It takes 10 minutes. We had our athletic trainers do it at the University of Colorado. They'd come meet us, we'd say hi, poke on their tendon, the athletic trainer would do it. They'd come back for an athletic training appointment every week for 3 weeks. So.
Not only do we have two trusted docs here, but to reinforce that PRP for 6,650, I can tell you right now the value, that is a great deal. So not only do we get quality in the doc, we get great value for our patients. So just keep that in mind when people are having conversations.
Yeah, we charge like $1,200 at University of Colorado, so it's a good deal. Very good.
I can't imagine people are doing it much cheaper.
Yeah, I like to. I like to, and really it's the kit cost from, we use an Arthrex machine called the Angel, which gives us the ability to do a leukocyte poor, leukocyte rich, and then a kind of a middle ground between the two. And we get the amount of PRP is based on the blood. So if I have people with like rotator cuff arthropathy who are looking for something before surgery, what we'll end up doing is taking a little more extra blood. Hey, instead of a quarter cup, we'll take a half cup. We spin it, we get 8 milliliters of PRP, and I'll put half in the cuff, and then I'll put half in the joint. And LRPRP is a little pro-inflammatory in the joint, but the pain control after the fact as it stimulates some of those cells inside the joint will also be beneficial. So we sometimes do like little 2-for-1 type deals just by drawing more blood, using it on the same kit. Sweet. Thank you guys.
Thank you.
Thanks for having us out.